Good morning, everyone. We're having a few technical difficulties. I'm sorry about that, but these things happen. I know that we're starting about 15 minutes late, but if you have questions, we've had a bit of an issue with that with our webinar stuff. But if you have questions, what you can do is actually send that to amy.dunn1@ky.gov. And she hopefully will be getting those questions, and then we can answer all those at the very end. Or at the end, you can also ask questions through the notes section, and hopefully we'll see all those. So, but like I said, I won't take any questions until the very end, but if you think of questions as I'm going, just send it to Amy's email address, which is amy.dunn, D-U-N-N, 1@ky.gov. And hopefully we'll get those answered, okay? So with that, I guess we'll start. So this is our wonderful annual training that we always do every year. I usually do it a little bit sooner, but didn't get any updates on the ICD-10 until I don't know how long, so it's been a while. So that's why it's a little bit later than what it normally is. So but let's go ahead and get this started. Maybe. Okay, now, sorry. Like I said, we are definitely having some technical difficulties this morning, but we're going to work through those. All right, so this is the same stuff that I go over every year. Basically just telling you about what I'm showing you that's going to be in this documentation. Basically the coding on the PEF, determination of new and established patients, coding of preventive visits, components for coding other than preventive E&M visits, which we call problem visits, coding of problem visits for new patients, and then coding of problem visits for established patients, multiple visits for the same patient on the same day, which I think we know how to do that by now, but if not, we can go over that too. All right, and then this is my slide basically telling everybody this is what I go through every year. I go over all this stuff, trying to refresh your memory on how you do all this. Just making sure that everybody's on the same page and that we have an attempt to do correct coding. But this is my presentation that essentially is for anybody walking in off the street, because as everybody knows that has been in the health department for a while, coding is completely different in the health department setting than the real world, because we have an actual contract with Medicaid to accept nurse coding higher than a 99211. So this is something that we deal with all the time. So just one of those things that I like to tell everybody, if this is new to you, then that's great. Just remember, it'll take a little while for it to sink in, but this is my way of saying, if it's not new to you, just remember there's other new people around you. So just count this as a refresher. Okay, first thing I have to do, of course, is the guiding principles. Only provide the level of care that is medically necessary per clinical judgment. All RNs need to provide and document services in accordance with the Core Clinical Service Guidelines, CCSG, and with established best practices. And number 3, always code and document, and then document one more time, exactly what care was provided. Okay, then we go into coding on the patient encounter form, or as we all call it, the PEF, which is the PEF. So also it has a number on it too, which is the CH45. But just so you know, there is a state PEF or a state CH45. However, you can create your own. You can actually change it however you want it. Just make sure you change it each year that you're looking at it to make sure that the codes have not changed. Also, we have a a flu clinic and school sites that, you know, like I said, it's all up to the health department, and if they want to change those, they're perfectly welcome to. So just make sure that you look at them each year is all I ask of you, to make sure that these things, that the codes are still up to date. And it is completely up to the health department to update those forms annually. Okay, so we're going to go into the codes. The first thing is the CPT code, which is what I call the what of your service. It's like your service that you're doing, your procedures and your services. So that's what your CPT code is, your what you're doing for them, your service you're providing. Now, your ICD-10 is actually your why. It's the whole reason behind what you're doing, okay? So I know I sound like a broken record, but your what is your CPT, and your ICD-10 is your why you're doing it. So that's what you have to think about it. That's the easiest way I can explain how to code something when you're doing something like this. Your what is your service, and that's your CPT, and your why is your ICD-10. That's your reason you're doing whatever you did. And based on that, I can actually show you an example here of what I was talking about. The CPT codes are the what, and the ICD-10 codes are the why. Okay, so with that being said, let's go into coding E&M visits on the PEF, or your CH45, whatever you want to call it, your patient encounter form. Because coding on the PEF actually consists of preventive visits, preventive E&M visits, like your well child, well woman checks, and then your problem visits, which are like your that's basically your supply visits, STDs, cancer screenings, that type of thing. And let's go over exactly where that is on the PEF. On the top left-hand corner of the PEF is where your preventive visits are, your well child exams. That's where you're going to code those. And that's, we'll go into exactly how to code those here in a little bit. Your problem visits are on the top right-hand corner of the PEF. And then we got our wonderful 992 codes, which actually, just so you all know, I didn't take the slide out because of the reason that I wanted to make sure everybody was using the 99 codes instead of the W92 codes. Because as of 7/1/18, we took the W codes out, and we no longer need the W codes, because we can actually track what you're doing based on your ID number. That's how we track things. So in my eyes, I think it's a better way to track instead of using those W codes. So I left this on here just to make sure everybody knows, and I wanted to go over it one more time just in case. But as of 7/1, I need you all to use the 99 codes that are on the PEF now. And if you notice on those previous slides, I actually had to take the W codes off of there, so it's a little bit, I'm going to say just a little bit, just a tiny bit bigger, but not much, because everything on that PEF is really small these days. But I have to make it small so you all can get as much as you can on it. Okay, and then of course, the other things that are on the PEF, if you look down below your preventive visits, that's where your labs are going to be. And then if you flip the PEF over on the back, there's a place for you to write in codes if need be. Okay, and then I wanted to make sure that everybody knows that the easiest way for you and your clerks to get along in your clinic is to make sure that your ICD and your service match up. The best way to do that is to make sure that they match up as far as your service, which is your preventive CPT code over here. That's your what you're doing, and your why is going to be in that box that is right next to it. And I give you an example here. If you'll notice, I took out the W codes, so there's just the 9 codes on this. So this is your example of what I'm talking about here. The best way for you to tell your clerk which one is the primary is to circle it. The ICD code, that is what I'm talking about. So you have a 4-year-old established patient that receives a preventive exam by a nurse and also receives vaccines. So you're going to have 2 ICD-10 codes. The first one is the Z00129. And the next one is going to be that Z23 dot. Don't forget the dot. But if you have a patient there and your clerk is actually trying to put that in, they don't know which one to put first. So in my eyes, it's best if you just circle the actual primary ICD-10 code that you want them to put in first. That way you both have a way of knowing what should go in the system as the primary ICD-10. Just something to think about. And I'm trying to lessen what everybody has, so, well, at least help. Okay, and then I have to go over, of course, every year, because this is the main reason why I didn't do this until later this year, is because of the fact that the ICD-10 codes, of course, they're not effective until October 1st, 2018. But this is for the 19 year, just so y'all know. It's one of those things that it occurs in 18, but it's actually for 19. So just kind of one of those things that we have to remember. So if you have any kind of cheat sheets or lists or anything like that you use on a daily basis, you need to remember to update these lists. I'm going to go over some of the new ICD-10 codes with you. There's not a whole lot that's going to pertain to us, but there is a few that I just kind of wanted to make sure you all were aware of, which is what I do every year, just to make sure that you all know about them. So with that, we'll go straight into it. Woohoo, right? I know y'all are excited. I can hear it from here, even though there's nobody in this room. Oh, sorry. I just got to look. Sharon Trevitt and Amy Dunn are in the room with me. I'm sorry, but nobody's really looking at me. So anyhow, okay. Now that we're done laughing at me, which is fine, we have a new guideline information that we need to go over. They actually changed a little bit of the guidelines this year on the ICD-10. And what this is actually the coding for healthcare encounters in hurricane aftermath. Now, this is kind of one of those things that I think maybe ICD-10 didn't think about until this last hurricane, which was a doozy. They actually put this in here so that we make sure that we are doing this the way it's supposed to be done. Because you have a way that you're putting the ICD-10 codes in, which is the use of external cause of morbidity codes, the sequencing, and then the other external causes of the morbidity code issues, and then of course your use of Z codes. Z codes usually come in the last place, but like I said, for preventive health, sometimes that's not the case. So, and it's all due to our cost center issues that we have to deal with. So, the other guideline that they have mentioned in the coding is the fact, excuse me, the fictitious disorder. That's something that they wanted to go over with that. That's actually something that they've added into the guidelines. There's also chapter specific coding guidelines that I wanted to go over with you just a little bit. For this type of issue, when you have drug use during pregnancy, then there's certain ways that you have to code that. So, and I go over with you everything that you need here if you ever need to go through this. So, but if you have problems with that, just send them to me and I can talk to you about it, and I can actually go through this with you so that we can make sure that we get this right. Okay, now we're going to go into actual changes, the new and deleted codes for ICD-10 2019. So one good thing, and I wanted to make sure I put this first and forefront, that there are absolutely no deletions, changes, or additions for A00 through B99. Hallelujah, right? No deletions, changes, or additions. That's a wonderful thing. Anyhow, so that's the first section that we wanted to go over. Then the next one, we actually do have a couple. There's not that many, like I said. What I thought might pertain to you all, I have put in here. There's some deleted codes just because of higher specificity. And let me tell you, that's hard to say, just anyhow. So what you're going to do is code it further out, essentially. So you have your E72.8. Well, if you look down below there, there's actually another digit on 2 of the new codes that's there. And they're basically just, you know, getting more specific on it. It's what ICD-10 does. So we just have to get used to it and keep going, right? So there's also E78.4 that was deleted, and that's only because they're adding more specifics on it, if I could actually get that out. Anyhow, so y'all know me. So that's what I'm talking about, is that the new code has a 4.1 and a 4.9. So you can actually get those further down than what they needed to. Now there's some more new codes here. I put that in red to show you that F53 has actually been deleted. But like I said, the only reason why it's deleted is because they're adding more to it. So just remember that if something's deleted, it's probably because there's another digit on it. So you look a little further down on the new codes and you can find it. Like if you look down here, F53.0 is postpartum depression. And then you have the F53.1. So you got all different things. Just remember there's probably an additional digit that has been added onto it if it's a new code or if it's been deleted. So you just kind of have to keep looking a little bit further. Okay, and I'm sorry, I was looking at something here. I did not actually add the H57.8. I thought I put those on there, but I guess I didn't. So what I'll do is add that to it and send that out, just so you know. I'm going to write that down right now. H57.8. I need to add some stuff to this slide because I thought I had it on here, but I didn't. Apparently there's, let me just tell you, on this particular diagnosis, I know why I didn't add this now. It just hit me. Sorry. There is all kinds of disorders of the eye. Well, they have gotten very specific in that they're getting right down to which eye, which eyelid, and if it's upper or lower eyelid. That's how specific this is getting. So I don't know that you would ever need those codes, but if you do, please contact me and I'll help you get through that, because there is a lot of those codes. They added, I don't know how many just on the eye alone and on the actual eyelids, and if it's upper, lower, outer, inner, that type of thing. So that's why I didn't add all those to this. It just hit me. That's why all of these are on here like this. But they deleted the one code and added, I don't know how many in its replace, because it was huge. Anyhow, but like I said, I don't think that's anything you all will ever have to deal with. So, but if it is, you know, you can contact me at any time. All right, so let's go on into I63.8. And this, again, same thing. They're deleting this one, I63.8, but that's because they're adding to it, which they're adding a 1 and a 9 on this particular code if you look down below there. So, and then actually, they've got a few others down there that have been added. So if I found any that were in that section that were added, I'm going to show it to you just in case. Okay, and then we have, let's take a breath. because we have no deletions or additions for the diseases of the respiratory system, which is J00 through J99. Woo, right? And I'm yelling for y'all. I'm woohooing for y'all. Okay. Now, we have a few that are added to the genitourinary system, and we have two that are deleted. But let me show you this next slide. Kablam! Let me go back. Because there's a lot that have been added to this. But I don't know if they're really going to be something you're going to use that often. But if it's something that you use, then this is why I put this on here, just in case you need it. So, but just know that the N35.8 has been deleted, along with the N35.9. That has been deleted. But the only reason why is because they added more to them. Of course, right? You all know how this goes. They added a lot more to them. So we have all these out here. I don't know that you'll ever really use these, but if you do, they're here. And also, if you have questions about them, or if it won't go in the system the way you think it should, then that's why I'm here too, to help you get through that too. So, but like I said, I just kind of show these to you. I don't want to try to scare you. I just wanted to show you what has been added. And that's what all of these are, is new codes. If you notice, I actually bold printed the ones that were related directly to female. The others are male. So the bold print is female, the other two, and that's basically two codes. You know, out of all of these codes, they're all male. If that is not crazy, I don't know what, but they decided to give females two codes. Woohoo! So that's why I actually bold printed those, just so that you all know that that would be what might pertain to the patients you're looking at. Okay, so now we have a few more on the new and deleted codes. Like I said, there wasn't a whole lot of changes, but there was a few, so I wanted to make sure everybody was aware of them. If anybody deals with, which I'm sure you all do, signs and symptoms and abnormal clinical and lab findings, let me just tell you, these were two that were deleted. These ICD-10 codes, which is the R82.99, which is other abnormal findings in urine. And then you have your R93.8, which is abnormal findings in diagnostic imaging of other specified body structures. So when you're actually looking at this 8.2, if you look down further, like I said, they just basically added another thing to it, another digit to it. And they have. If you look right there, you actually see all of what it's added to it. There's 1, 2, 3, and then 4. So, and then it actually jumps all the way to 8. I guess they're waiting for other things to pop up. I don't know. But that's what you can actually code now to make sure that those are actually going to the right place as far as cost centers and stuff like that. But in all honesty, I think that they added on more stuff to get more specific. That's what ICD-10 does. Specific. All right. And then I go over, there's some new codes in the S00 through to T88, which is injury, poisoning, and certain other consequences of external causes. T43.641A through T43.644S, which I'm sure you all are all aware of the A through A, D, and S. But all this has actually been added basically because it's poisoning by ecstasy. So that's something that I just wanted you all to be aware of, just in case you were to need that. And then there's also, we actually have our Z codes, which we use a lot of. But here's a few that were actually deleted, but they weren't, like I said, if it's deleted, that usually means they added something to it. So just look a little further, go a little bit more specific, and it will give you what you need, hopefully. You have the deleted codes, which is the Z04.8 and then the Z13.4. And of course, down here at the bottom, you have new codes, that is Z04.81 and then Z04.82. So it gets a little bit more specific. It's usually what it does. And then we also have the Z04.89. Again, this is actually one that is for other specified reasons. So that's one of those, it's a generic, but not quite, you know, one of those types of things. I give you a few more of the new codes that have come up. And this is Z13.30 all the way to 39, although it does skip a few because it goes to 32 and then it stops and then goes to 39. I guess they leave those there in case they find other stuff. I don't know. I don't understand that, but they do. So, but I've labeled all of this out here so that you all can see this. There's also something you might be interested in is the Encounter for Autism screening. That's out there. There's also the screening for the global development delays, milestones, which I'm sure you all are aware of because we all have to have our wonderful WIC growth charts and all that good stuff, but that has nothing to do with clinical. And then we have our family history of elevated lipoprotein, or also there's family history of other disorder. You know, there's all kinds of stuff, but I just wanted to show you all these so that you know how specific ICD-10 is trying to get. So that's at least something. Okay. Now that we went through all those wonderful ICD-10 codes that are new for 2019. Sorry, I had to take a drink. We'll go into determination of new or established patients, which is the same stuff I go over every year just because I want you all to remember how to do this. And if you don't know how to do this, we can go over that right now, exactly how to do this. So, sorry, hang on just a minute here. Sorry, technical difficulties there. All right. So we go over where everything is. That's what I do on everything here, which I'm sure if y'all been around any time at all, you know I'm like a broken record. I just repeat stuff over and over and over. Anyhow, so you have your PEF, and on the left side you have your new patients, and that's actually going to be in the pink side of your preventives there, and also your problem issues, your problem visits, which are in the pink as well. And if it's in blue, then that's your established patients. So just something to know where things are. Now, how do you determine if it's a new or established patient? Well, I'm glad you asked that question. If the patient has not been seen within the county in the past 3 years, they are considered a new patient. And it goes right down to the specific date. So if they came in and it was 2 years and 11 months and 29 days, they are still an established patient. If they come in at 3 years and 1 day, then they're a new patient at that time. So, and it is based on county, not district. So if you're in a district, it's county based. So just remember that, okay? We have a system, our CDP system, which they call it clinical management system, but to me, CMS is Medicare, but anyhow. So like I said, clinical management system, or CDP's system, where the PEF label is created. This is something that we can use to help us on determining if it's a new or established patient. However, I don't want you all to get dependent on that because sometimes it may or may not be right. Although I have not been able to prove it wrong yet. I'm working on it, but I haven't been able to do it yet. So, But if you are in a satellite clinic site and you're trying to, like a school or something like that, it's easier to look at your chart and determine from that. But because you're not going to have that sticker in front of you. I don't know what happened here, but it looks like I have an extra slide in here talking about the new and established patient. So sorry about that. Let's move on. Maybe I have two there. Maybe I went up. I think I did, sorry. Okay. If you are a provider that is in one of these satellite clinic sites and cannot determine as to whether or not they are new or established, and you don't have that PEF label in front of you to look at it, it's almost easier to just go on and code for both just in case, I guess you could say. So you don't have to look at that PEF again, because the clerk that's putting that in the system is not going to have any idea whether or not this is a new or established patient unless they are looking at it in the system. And most of the time when they see it, they're going to have that. But you, as the provider in front of you, you have the patient in the chart. You may or may not have the system to back you up. If that is the case, you can code for both. I've showed you an example of how to do that. What's going to happen is once that clerk actually gets that in front of her, she's going to have the system that's actually going to spit out a label that says new or established. And based on that, she can mark through whichever one is not correct. Just something to think about. However, I always tell everybody this, if it's not marked on that PEF the way it is right here, that clerk cannot go up and put a check mark next to something because she really doesn't know what you did for that patient. He or she, I'm sorry. He or she does not really know what you did for that patient, so they can't actually code for that. And that could get them into trouble, especially since you, the provider, are the one who has to determine the level of the visit. All right, so now that we've gone through that, new and established patients, let's go through coding of preventive visits, which is very simple. You essentially have three things you're looking at when you're coding preventive visits. You have new and established patient status, age of patient, and the completion of physical exam by protocols, which are listed in the CCSG. So that's essentially all I have for the preventive visits, which is pretty simple depending on how much you have to do for that annual exam. Now, problem visits. Let's go into that because this is where everybody usually gets a little tripped up on, but let's go into it. Okay, so we have our problem visits, which when you're coding, you actually, it's three key components is what I call it. Your history, which is your history of present illness, review of systems, past family and social history, exam, and number 3 is decision making. These three components are the driving forces behind the coding of problem visits. You have to understand these three components to accurately code problem visits. So for that reason, I'm going to show you, most nurses know how to SOAP note, which is how I'm going to try to show you to pull out what you need in order to code for these. You have your S part of your SOAP note, which is your subjective portion, and that's where you're going over your history of present illnesses, review of systems, your past family social history. You have your O, which is your objective, and this is when you're actually, the provider notes when assessing the patient. It's like your exam portion, and this is actually something that we'll discuss more on new patients, so we'll get further into that, just so you know. And then you have your decision making. Decision making actually consists of three parts. You have your presenting problem management options, which is your assessment portion of your SOAP note. So after looking at the patient history and performing an exam as needed, the assessment of what the patient's problems are. That's essentially what the first portion of this is on your decision making. And then you have your second option here, because I said there's 3 different parts of decision making. The second one is diagnostic procedures ordered, like any that a provider must decide if any diagnostic procedures should be done. Management options selected, like what treatment the patient should receive. And this is actually your P part of your SOAP note, which is your plan. Okay, so now that we've gone through that, let's go into new patients. The AMA actually requires that you have all 3 key components shown in your documentation for a new patient. Okay, so you have to have some history, some exam, and some decision making. If you do not have one of those, then you don't have a visit. That's all there is to it. Because the AMA says that you have to have all 3 of those key coding components in order to have a visit. Now, the exam component is going to be what you're going to determine as the exam component will be the lowest of the 3 components 99% of the time in the health department setting. I've looked at I don't know how many charts, and every one I see, it's always exam that gets everybody every single time. So what I have devised, or what we have decided to do, is to actually show you how to count up your exam bullets and code according to that. That doesn't mean that you don't have history or decision making. You have to have those too, but what you're going to code to for this is going to be your exam component. Because you actually have to code to the lowest part, and every time this gets you. Because the exam is what we talk to them a whole lot, but we don't like to touch them, which is fine, but again, just something to think about. You have to code to the lowest part, to the lowest thing of what you're doing for the AMA. I'll also give you, if you need the complete list of the exam bullets, I can actually have this in here, but if you need this, just let me know and I'll send it to you. It's fine. It's not a big deal. I don't mind to do that at all. But here's what I go over just to show everybody that you actually can have the 5 most common bullets. If you notice on this, there's actually, on our HMP 13 and 14, or CH 13, 14, they used to call it CH, but now it's HMP, history and physical. But anyhow, they actually put general appearance and nutritional status in 2 separate lines. That's actually 1 bullet, okay? So that's only 1 bullet, just so you know. But, so you have that, your general appearance and nutritional status, that's 1. Mood and effect, that's 2. Your orientation, that's 3. Excuse me. And then skin, you actually can get 2 bullets for that if you have inspection and palpitation, okay? So that's your skin warm, pink, and dry, you know. So that's actually 5 right there, those first 5, okay? But if you add 3 vital signs, because it's a 3 for 1 when you're thinking of vital signs, to get 1 exam bullet. It's a 3, you have to have 3 vital signs to get 1 exam bullet. So one of the 3 that I've listed down below, or even there's more, but I couldn't fit them on the slide. So, but it has to be a 3 for 1 when you're talking about vital signs. Okay. And then you can get that additional bullet, which would get you up to 6 on this slide. Because I list out 5, and then I give you 1 more option of if you wanted to do 3 vital signs on a patient, that would bring you to 6. And then it's pretty specific on how you can actually code according to what you're doing as far as exam bullets. So you have your 1 to 5, excuse me, which is your brief. And I am sorry, This is one that I did not see. I meant to cross through those W's, but I did not, and I'm sorry about that. That's my fault. I'll take that off next time. But use the 99201 for the 1 to 5, which is your brief, and then your 99202 for your expanded. And then you have your 99203, which is your detailed new patient, and that's 12 to 17. Now, that's a lot of exam. So I don't know if you wanted to look and see if they've had their preventive for this year or not, but if they have, it might pay off to flip it to a preventive if you're doing that much exam. I don't know. It just depends on what all you're doing for that patient too. So the next thing, and that's 18 to 23 for a comprehensive, which is the 99204. And then 24 or more bullets is the 99205, and that's a complex. Now, and I always tell everybody this because I want you all to understand what the AMA is actually expecting of you as a medical provider. They want you to do a more thorough exam, within reason, of course, on a new patient to provide a good baseline for future visits. And that's actually in a KAR. So just something to think about. It's one of those things that when that patient comes back, if you didn't get any vitals on them, then you're not going to have any way to know if this is normal or not. So just something to think about. And I want you all to understand the AMA actually expects it of you. So let's go over how to code again, because like I said, I am a broken record and I know this. I say it over and over and over. Remember to have some history, some decision making. However, the coding for new patients is directly related to the amount of exam bullets performed, as it's usually the lowest component in the health department setting. So basically what you're going to do is you're going to have some history and you're going to have some decision making, but the way you're going to code for new patients is going to be how much exam bullets you have on that patient. And you're going to count that number of exam bullets and code accordingly. Hey, and I remembered to knock out the W on this one, just so you all know. So according to the coding criteria for coordinated school health, APRNs and registered nurses may code a 99201 and 99202, depending on how much exam they're doing in the schools. So again, you're going to have to count up your exam bullets, make sure you have some history and some decision making, but the way you code is according to how many exam bullets you have in the school setting. But also, just so you know, the highest you can go on this one would be the expanded according to the coding criteria for coordinated school health. Okay, and then we have established patients. To code for an established patient, you actually only have to have 2 of the 3 key components. So you have to have some history and some exam, or you have to have some history and some. Now, I usually say that you have to have decision making, because how else are you going to tell the patient what they're going to do? You know what I mean? So you'd have to have some history and decision making, or some exam and decision making is what I would think. But that's just me. So otherwise, you would have no plan for that patient. But the level of visit chosen for established patients will be driven by the lowest of either the history component or the medical decision making component. The exam that is performed should be what is required by protocol or medically necessary. So I think this is the easiest way to teach you all. And just so you know, I forgot to mark out the W codes on these too. Sorry. So it's actually for an established patient brief. You have no history taken. Decision making is minimal. No review of systems. This is where you're basically coming in, the patient's coming in, and they're coming back for their TB skin test reading. And it's negative. So all you're doing is going down their arm and making sure that it's negative. So there's not a whole lot you're doing for that. It's just a one line in your notes that you're doing. You don't want to do a soap note because it makes that raises the level of visit, which you don't need to do. So, and it also wastes your time. The next thing that I have is a limited established patient, which requires 2 of the 3 key components. So you have a problem-focused history, straightforward decision-making, and this is basically 1 or more self-limited or minor problems. Okay, so I give you some examples down here. Let's go through that. This is where you have a supply visit with no complaints, no problems. She's just coming and she's like, I want my pills, I need my pills, I gotta have my pills, you know. And then your STD screens. I'm so-and-so down the street said that so-and-so might have this, so I'm here to get checked. You know how that works. So that's your STD screen with no problems or negative results. This is the initial STD screen too, because they're coming in and they don't have any issues, but they've heard that so-and-so might have had something, and you know how that works. So, but this is the initial STD screen. So, and they don't have anything at this point because you don't know whether or not they do or not. And then we have head lice, and this is either suspected or found, because what are you going to do for that head lice? Tell them to go home and treat it. Then you have your expanded. Sorry. This is where the patient comes in to receive their depot. They've had a small weight gain of 5 pounds since the last visit. The occasional headache. They're like, it's okay, it's fine. I just want my depot because I can't remember to take those pills. So you counsel them a little bit more about it and make sure that they understand the issues that's going on with that, and that if they worsen, they have to come back in and all that good stuff. And once you counsel them and they say, yeah, I still want it, then you go on and give it to them based on your medical decision making, then that's fine. But that does raise that to an expanded. So this is how, that's actually where that's going to stay, is at the expanded level, which is the 99213. So, and we have also positive TB skin test readings. This is where this is going to stay as well, because you're doing a lot more for that patient. You also have positive STD visits with treatment, and that's also going to stay at this expanded level because you're doing a little bit more for them. So, hang on just a minute. Now, the next one that we have here on established patients is detailed, which is 99214. And this requires at least 2 of the 3 key components. And this is actually when the patient comes in and they're presenting problems of moderate to high complexity. And I give you examples because honestly, I think it's the easiest way to show you all what I'm talking about when I do this. Sorry. The example that I give you, I'm sorry about that. The example that I give you is the true contraindication to the contraceptive method. Now, this is when you have your OCs and the patient comes in and you take their blood pressure, and their blood pressure is like 160/92, which is pretty high, I mean, just saying. And they're also complaining of severe headaches daily with visual impairment. And you decide, you know what, I'm not giving this patient anything until they see somebody else. Then this is where this is going to be raised to the detailed level, because you're making that decision to say, I cannot give you anything until you see someone else or until you get further evaluated. If that's the issue, then that's where this is going to stay, is at the detailed level. This is also another example that I give is patients presenting with problems significant enough that more case management is necessary. So, and that's actually when you have a patient with an abnormal breast exam where you're saying, hey, you've got an issue, I found something, you need to go see somebody else. Again, making sure that they get further evaluated. So it's more case management on your end, essentially, is what you're thinking about here. And then I also have another detailed here, which is the 99214. And this is where you have a positive pregnancy test on initial PN visit, and you're talking to this patient and you're going over their risk factors. If they have 2 or more risk factors, then that actually can be considered a detailed visit. So if you have a patient in front of you and they're a smoker and they're obese or their age is young or old, you know what that is. Or if they also have a history of miscarriage, high blood pressure, early labor, preeclampsia, STI with pregnancy, that's even a risk factor. But if you go through all those risk factors and you find 2 or more, then that actually can be a detailed visit. Just remember, I forgot to cross out these W codes on these, but just know that you need to use the 99 codes on these for now. So, but this actually can be a detailed visit because you're going through those risk factors. And if they have 2 or more, then that essentially is a detailed visit because you're going into those issues. They're already pregnant, so it's a positive pregnancy test first. So you know that they have a problem. And then if you go into all the risk factors, then that's even more of an issue. And again, they're going to have to be further evaluated. So that's how you have to think about that. All right. And then I give you comprehensive for an established patient. Let's give you an example here. Your example, of course, is HIV, rape, anaphylactic reaction to vaccine, or any time that patient leaves your clinic by way of EMS. I'm sure you're probably not just sitting there looking at them saying, I guess the EMS needs to come get you, huh? No, I don't think so. I think you're probably doing a little bit, probably a lot more than what you think you are for that patient to make sure that the EMS can come get them, because you don't want them to, fall out right there on the floor and just leave them there and say, oh, EMS, that's your problem. No. If you're doing everything you possibly can to keep that patient alive until EMS gets there, then think about everything you're doing. Make sure you document it. And this actually can be a comprehensive visit, which is the 99215. Okay. And then, of course, for school, we have 2 that you can actually code. For some reason, I took it out on the school, but not on the other ones. But anyhow, sorry about that, people. So the 99211 is what you can do. This is for your patients that have simple, self-limited, or very minor problems according to the coding criteria for coordinated school health. And I give you all your examples right there. I also have your limited visit, which is the 99212. Again, this is where you have your patients who have more complex, self-limited, or minor problems according to the coding criteria for the coordinated school health. Now, multiple visits for the same patient on the same day. Woohoo! Sorry. I'm trying not to be boring, people. I'm sorry. I know I am, but it is. It is what it is. Okay, so when you have a patient that has a couple of things going on, this is where the 25 modifier may be able to come into play. So if that's the case, let me show you where it is on the PEF in case you need it, which is right underneath your other than preventive health check E&M, which is your problem visits, which we all call that problem visits. I don't know why I don't put that on the PEF, but I don't. And it's right below those visits. That's where your 25 modifier is. And when you put that on the PEF, the clerk should know that it just attaches to the actual CPT code, which is, so it would be a 9921125 if the clerk was putting it in the system, just so you know. Okay, so, and like I said, it's easiest to just show you an example and teach from that. Sorry, I'm losing my voice. Okay. 39-year-old established patient comes in for family planning preventive visit. While doing this patient's family planning preventive visit, the APRN finds vaginal warts and with the permission of the patient, treats. The coding for this would consist of the 99395 for the actual annual planning, the actual family planning that the patient came in initially for. But if you think about it, the APRN actually did something else, because while she was doing the preventive, she found something else and then figured while she was there, she needed to treat something else too, which is the warts. So if that's the case, it's going to come to, you're going to code that preventive, which is the 99395, along with the problem visit, which she has a problem because she has warts. So you're going to definitely code an expanded, which is a 99213, and then you're adding that 25 on there so that both those visits get paid. I'm not going to promise that they get paid because we have MCOs, but I'm hoping that they get paid. And this is actually the correct way to code this. So all I can do is show you how to correctly code it. And the insurance should pay it this way, but like I said, all I can do is show you how to correctly code it. I hope they pay it, let's just say that. So now we're going to do a different example because I wanted you all to know about this one too. Because when you have your 17-year-old established patient that comes in for family planning supplies, and the RN finds out after she's talked to her for a little bit that she's not received her HPV-9 vaccine. So if she decides that, hey, wait a minute, and I don't even know if that's the right one or not, I just stuck that in there because I did have Gardasil and everybody said that's not right, we don't use that anymore. So anyhow, the HPV is what I was trying to say. The patient decides, hey, wait, I think I do want to get that vaccine. And you counsel her per component. The coding of this would actually consist of your 9921225 for the actual family planning supplies, because that's the main reason she came in, okay? And you're going to put the ICD-10 that relates to that family planning issue on with that particular 9921225 code. And this is so that the insurance knows that you're not just tacking on an office visit just because they came in and got a vaccine. This is actually something that you're showing them, hey, the ICD-10 is actually something separate from what was actually done. Because she came in for family planning supplies, so that's what the ICD-10 is going to go to. And then you're going to put on that 90460 and then 90651 for the actual administration of the vaccine and the vaccine itself. The administration, of course, is the 90460, and then the vaccine is 90651. So I hope that I didn't confuse you on that, but the reason why I'm telling you that is so that the insurance knows that there were two reasons. She came in for one thing, and then you found out that she needed something else. So that's why you're adding that 25 to that office visit, so that they understand that. Let's just hope they do. Okay, So I had one small issue that I was taking off because we don't really track these anymore. And if y'all are doing it, y'all don't need to. It's one small change to the PEF. It's basically the blood pressure measured has been removed off of it because it's a data point that we don't need anymore. And actually, nobody here at the state is really looking at that. And I think that's crazy for you all to have to check that and put that in the system. So I took that off. There's just not something, it's not something we actually have to have. Now, if it is something that you do in your clinic, then leave it on your PEF. That's fine. I'm just saying, from a state standpoint, we don't have to have it. So I took it off for that reason. And then, of course, oh, and the only other thing that I had here, I have to go over one more time just to make sure everybody knows the guiding principles. Only provide the level of care, excuse me, if I could talk would be good. Only provide the level of care that is medically necessary. All RNs need to provide and document. Oh wait, and the document again. Services in accordance with the CCSG and with established best practices. Always code, and hey, wait, there's that word again. Document exactly what care was provided. Because if it's not documented, it's not done in the coding world. That's just how it is. And then I'll tell you where I get all this good stuff. And questions. So and just bear with us because Amy and I don't have a system down quite on this, but we will. Hang on just one moment and I'm going to get the question from her and then I'm going to, repeat it and answer it. Like I said, I just basically talked to myself up here. Hang on just a minute. Okay, we worked it out. All right, so the first question that we have is lead. So how do you correctly code a lead visit with WIC and without WIC? Well, first off, people, let's think about this. What have I said about WIC? WIC is not medical at all. WIC is not a medical visit. So you're going to code lead the same way you would with or without it. You're going to code what you're going to do for that lead. So what are you doing for this lead? Are you doing this based on WIC, that you're doing something with WIC? Are you doing like a finger prick or something like that? If it's an established patient for a lead, think about what are you doing for this patient, you know? I mean, and are you in a high risk lead area too? That's all things that go into this. I'm not going to tell you exactly how to code that visit, but most of the time when you're doing lead with a patient with WIC, it's not usually going to go above a limited. Now, and that depends on your area and what all you're doing for that patient. So, but just so you know, I hope I didn't confuse you, but I'll go into these a little bit further too, and I'll send out an FAQ too, just so y'all know. The next question, excuse me, that I have is when a patient comes in for WIC and is postpartum, can we code Z13.2 separate? I don't know exactly what you're talking about there. Hang on just a minute. Let me look at my note here. I might have. Okay, well, my first issue with this question, let me repeat the question one more time. When a patient comes in for WIC, ding, ding, ding. When a patient comes in for WIC and is postpartum, can we code Z13.32 separate? Let me ask you a question. Are they coming in only for WIC? If they are you actually treating them clinically, or is it just WIC? Because if it's just WIC, then there should not really be an office visit with that, unless you're seeing them for something other than WIC. Just something to think about. Okay, so the next question that I have is please go over the difference between 99204 and 99205. Well, first off, these are new patient visits. Let me go back on my slides. Maybe. If I could get this mouse to work, it would be great. There we go. All right, so let me go back on where we were finding new patients, which is right here. Now, if you look at this particular slide, you'll notice there's a 99204, which is actually a complex. Hang on, I'm sorry, this mouse is giving me fits. Comprehensive, excuse me. See, that's why I wanted to smaller my screen, but anyhow. So that's actually a comprehensive exam for a new patient, which is 18 to 23 exam bullets. So just take a look at this slide. It's slide 45. This actually tells you when you're coding for a new patient, you have to count up the number of exam bullets, and you're actually going to code according to that. So if you're going to do the 99205, you're going to have 24 or more bullets, and that's a complex is what that is, okay? So you have to think about it like that. That's the difference between those two visits. Like I said, it's right here on the slide. You want to refer back to slide 45, and that actually will show you the difference between that. Okay, so the next question that we have is a new family planning patient that has a problem with her visit. Okay, we code her new under the preventive side, which is correct. You do want to code them under the preventive side. And then the next part of this question is, do we code new patient on the E&M side, the problem side, with a 25 modifier for the or established patient? The answer to that would be they are an established patient once they're new on the preventive side, because you've seen them for their preventive. Now you can move into the established patient side when you're actually coding that problem with that 25 modifier. Okay, and hang on just a minute. We're getting another one here. And this is, the question is, in your example of preventive well child with immunizations, you put both ICD-10s, both exam and immunizations on the preventive side. We have been coding preventive side for well child and also modifier 25 for the vaccines. Is this wrong? You know what? I'm glad you asked that question. It's actually not wrong, because I know the MCOs were looking for that 25 modifier. The reason why is because they were not paying the way they should have. And I know that the third-party billing team actually told you all to put that 25 on there, and that is right, because the MCOs were not paying the way they should have. I'll just say that. So that is correct. The next question that I have here is, can you tell us the reimbursement rate difference for brief, limited, expanded visits, etc.? Okay, so this is all listed on our preventive fee schedule. On the Medicaid preventive fee schedule, that's where you can find that. If you don't know where to find that, send a question to the local health.help desk and we can point you in that direction. So, right here. All right, I have another question here. Excuse me. Are there any ICD-10 apps that you recommend to help with coding? Well, there's all kinds of apps out there. Let me look. I don't want to answer that right now just because I don't want to point you to a specific thing and it be wrong. So I would rather investigate that. And then what I'll do is when I send out my FAQ, I'll make sure that everybody knows what I'm pointing you to. And then we might have another one here. Hang on. Huh? There's a ton of them. Why can't we move that down some? Okay, also, just so you'll know, I can't see the questions on this webinar for some reason. It's not working exactly. I told you all in the beginning, we were 15 minutes late starting because of our technical issues. So I need you all to send your questions to Amy, amy.dunn1@ky.gov, and she will be able to get those questions to me. So please send those questions to her, and I'll actually go over them online here if we can. But I need you all to send those questions to amy.dunn, amy.dunn1@ky.gov, and she can actually go over those. Well, I can go over those questions if you'll send them to her. But I can't, for some reason, I cannot see the questions on this webinar for something. And it's not working well, but anyhow, so I just thought I'd let y'all know about that. But like I said, and also you can send me questions too after this webinar is over, and I'll go over whatever I can too, just to make sure that you all know about them. There's another one. Okay, so we just got one. And just so you all know, I will be sending out the answer to all the questions, basically what I'm calling the frequently asked questions, the FAQ. I'm going to send that out so that everybody knows what the answers are to all these. But again, if you have anything, Amy, AMY.DUNN1@ky.gov. I'm sure she's happy about the fact that I keep posting, blasting her name everywhere. Like I said, she's so happy to have me as a neighbor too, you know. Okay. How does a licensed diabetes educator RN code for diabetes education given in clinic? Well, did you do an office visit with this patient? And are you actually just counseling? There's a whole lot of ifs, ands to that I need answered before I can say, this is how you code it. I need a little bit more information on exactly how you're coding for that. Like, as in, are you just doing counseling? Are you doing some exam? Are you doing some history? I'm sure you're doing something so that you know what to go from. So just send me a little bit more information and I can go over exactly how you would do that. So anyhow, I guess we are done because Amy's not getting any more emails. Again, that's Amy, AMY.DUNN1@ky.gov. If you have a question, otherwise you can send them to the local health.help desk as well. Let me put that back up for you too, just to make sure. Well, maybe. Hang on just a minute, people. I'm getting there. So if you have questions, you can send it to this email. The other one, of course, is mine as well, which I'm Cynthia. Just remember my H, CynthiaH.Robinson@ky.gov. So just know that I will answer as much as I possibly can, and I will be sending out an FAQ to let you all know what the answers are to all these. So, oh, we got another one. Hang on. So this question is, the referral section for the office visit preventives isn't on the PEF, which is correct. Do we still report referrals? At this time, I think you still report the referrals. I will check to make sure, and when I send out my FAQ to make sure that that's what you do, then we can go over that. But actually, that was never on the PEF. It was actually on the coding sheet, which I'm going to be doing a new one of those as well. I'm just trying to get that underway too. And I'll send that out with the information to the FAQ. But just so you all know, I'm on vacation next week, so it'll probably be the next week after that. So I also was asked to go over some flu. Oh, well, hang on, we've got another question. No, the question that we just got is, would the W code still be used for TB-DOT? No, the W codes are basically obsolete. As of 7/1/2018, the W codes should not be used anymore. You need to use the 99 codes for that. So even when you're doing TB-DOT, like home visits, you're going to use the 99 codes again. And this is going to be on that coding sheet that I'm going to send out to everybody. So, because I know we haven't had one of those for a while, and I think I needed to update it, and I need to get some more ICD-10 codes that are readily available on that, because right now all we have is ICD-9. So once I get all that done, then I'll be sending that out so that everybody has that. But I do know that I had somebody last night asking me about flu codes, that I needed to go over a little bit of that. So when you're doing flu, I just wanted to reiterate that so the issue is that when you're doing flu codes and you're actually coding, like you have a patient that is 65 and older and has Medicare, the way that you can actually code that is that patient has Medicare. So for this reason, they have Medicare, you're going to use that G code, which is the G0008 for the administration of the flu vaccine and whichever vaccine you're actually using on that patient. Okay, so the administration and then the vaccine code is how you're going to do that. Now it depends on, and even if you're doing like the high dose, that would be the 90662 with that G code. And that patient that has Medicare as a primary, and you're sending it to Medicare, or even the insurance that is like the Part C, I think is what it is. I can't remember off the top of my head, but where they're actually using an insurance as their Medicare, they will accept that G code. So, but just know that that's part of their Medicare. So that's why you use that G code. If that patient actually has insurance, they can also use the 90471 if they're 19 and over, and then use that vaccine with them. Okay. So if you have a patient that has VFC, that is eligible for VFC, and they are 18 and under, then you're going to use that 90460 as the administration and then the vaccine that you give them. Okay. So hopefully that explains that a little bit. I hope I didn't confuse you further, but we have some questions on that. Hang on. Actually, I'm sorry, 3 questions. My bad. Amy's correcting me. Okay, one more. Can you explain the MNT codes, new and established? Okay. All right, here's the issue with the MNT. For some reason, CDP does not show a difference between the new and established. It's something that I'm working with Kazi and Gary Kazi with CDP, trying to get him to get that corrected the way it should be. But it's one of those things that it's still a work in progress, and I'm sorry about that. But your medical nutrition therapist should have an idea as to whether or not that is a new or established patient, and they should code that according to the chart, not according to the actual labels in the system. So it's something that I know about and I'm trying to work with Gary Causey about. The next question that I have here is, if a child comes in with no insurance, do we charge an administration fee for VFC? You can, yes, you can charge an administration charge for VFC because you can charge up to $19.93, even if they are eligible for VFC. Hang on just a minute here. Okay, so here's another one. Okay. All right, here's the situation. Here's the question that's being asked. Can you confirm that we do not PEF for daily meds given in the school setting? Here's my question to you all. Is it something that you can actually relinquish, like as in, can you teach somebody else to do that? Oh wait, the school personnel, can they do this? Yes, they can. So for that reason right there, you cannot do that. You cannot PEF for those, for the daily meds. Can care provided in conjunction with an IEP plan in the school setting cannot be PEF'd? I don't know how that's. Any care, I'm sorry, my bad. Any care provided in conjunction with an IEP plan in the school setting cannot be PEF'd? That's the question that I get. If it's with the IEP plan, as far as I know, I don't think that we can actually do anything with that. My thought is, no, you cannot do anything when it's the IEP. That's part of the whole IEP process. But if it's something outside of that, maybe you can, but if it's part of it, then no, I don't see how you possibly can. Hang on just a minute here. All right, well, I think that's all the questions that we have so far. If there's anything else, just send them to me via email, and you can actually send them to that help desk that I have showing right there, that email, localhealth.helpdesk@ky.gov. Any questions like that, just send it into that, or you can send it to me too, and I'll answer as much as I possibly can before I leave for vacation on Monday. So hopefully I'll get all those done, but if not, I'll get them done as soon as I get back. Thank you all for listening to me, and hopefully I didn't bore you too much, but until next time.